Good morning. I'm Dr. Sean Coomer, Chief Medical Officer for the Kansas City Division of the University of Kansas Health System. Welcome back to Open Mics. For many amputees, losing the limb is only part of the challenge. Some people face excruciating phantom limb pain, the sensation that feels like it's coming from an arm or a leg that simply isn't there. But advancements in nerve surgery are offering new hope. Targeted muscle reinnervation, or TMR, helps rearrange the nerves, giving people who lose a limb some pain relief and better connections to some prosthetic devices. Joining me in the studio today is Dr. Jacob Brubaker, an orthopedic surgeon and microsurgeon who specializes in peripheral nerve surgery. Thanks for being here.
Very happy to be here.
Appreciate it. We are also speaking with the star of the show, one of Dr. Brubaker's patients. J.D. Van Pelt lives in St. George, Kansas, and for those who don't speak Kansan, that's just west of Topeka. He had an above-the-knee amputation some years ago and felt phantom pain before coming to see Dr. Brubaker. J.D., I'd like to start with you. Thanks for being here.
Oh, thank you.
Why did you need this amputation in the first place?
I actually had my leg amputated in June of last year, and just through after it healed up and trying to wear a prosthesis, and I could only wear it for like two and a half hours at a time with by just excruciating pain and couldn't have it on any longer. So I went and got a second opinion through KU Medical and got with Dr. Weiss and Dr. Brubaker and got this plan together to redo my nerves. So that's how it all began.
Right. Can you describe phantom pain to us? What's the sensation and how frequently did you feel it?
Oh, it was 24/7. I mean, I never really had a time I didn't feel like that. Foot and shin and calf muscle and everything was still there. It just all the time you could feel it and nothing really you could do about it. I've tried mirror therapy. It really didn't work for me. And the only way I knew I was going to be able to get on with my life and was to do this surgery and have a better future.
Yeah. So it wasn't pain at the end of your amputation. It was pain that was lower in the leg that wasn't there that you felt.
Right. Yeah. I mean, that, and I had a few sore spots on that stump, but that was pretty much it. I mean, yeah, it was just all the time.
Yeah. Dr. Brubaker, can you explain how phantom pain happens? Where is the pain sensation coming from?
Well, we know that peripheral nerves have the ability to regenerate. So if somebody has a laceration of a nerve at the knee, the cell body resides in the spinal cord and it starts to try to grow back and reinnervate the foot. When a patient has an amputation, just speaking of the lower leg, the limb is removed above the knee or below the knee. The nerve doesn't know that the foot is no longer there, and so it thinks, okay, it's time to regrow, time to regenerate and find that foot. As it starts to grow back, it's looking and looking and looking for that foot and that calf and those muscles and hoping to find its target, but it just can't. Mm-hmm. And that sets up kind of, in some patients, can set up this awful loop of having this sensation of the nerve trying to find the limb.
So when it tries to grow, how does it manifest? Does it just kind of spin on itself?
Yes, and so that's what when we talk about a neuroma, which hopefully we'll see a little bit later in the videos, is the nerve is just keeps on trying to send it's like a cable full of these fascicles of nerve fibers, and they just end up forming this big ball, and it can be quite impressive with the size. And some patients are super symptomatic. People with amputee issues related to the nerves have kind of two flavors. One is pain directly at the neuroma, which JD was kind of mentioning. You can actually touch the end of the neuroma and it just lights them up. And that can be a real difficulty for patients wearing prosthetics, and that's how that might present. The other flavor is the phantom limb pain, which is just as JD was mentioning, a 24/7 kind of sensation. Mm-hmm. For some people, it can be mild, and they say, "Yeah, I still feel my foot." And other people, it feels like it's in a vice, or I've heard, I've heard all kinds of descriptive ways of the way this manifests.
Okay. But it's not always pain, though. How else can it present?
Yeah, so, some patients, pain and a lot of the things that I'm a part of, if somebody breaks their forearm, it's a pretty straightforward the type of pain that they have and where it is. Nerve pain, because it's this interconnected system, it can really present in a lot of different ways. And some people will have, just a burning type sensation. Other people, it's pain. And like I said, people will come in and they don't know how to describe it. They'll say, oh, it feels like somebody's stabbing my foot, or it's in a vice, or, those types of descriptors. So it can really run the gamut in the way. And sometimes we just have patients who just say, I can't wear my prosthetic. I don't know what's going on. It's been resized and it's been padded and all these different types of things, but I can't be in it for more than an hour or two. And that's where we have to kind of dive a little deeper to try to figure out what's going on.
So when someone gets an amputation, what's the chances they can wind up having phantom limb sensation? Yeah,
good question. We think, looking back, it's probably at least 50% of patients have moderate or severe post amputation pain. And for those in the moderate category, it may be relatively well controlled with medications and different types of therapies. About a quarter of people like JD develop really kind of life-altering, life-interfering type pain. So about 25% of those patients have significant.
Have techniques gotten better over time compared to when I was learning in my general surgery days how to tuck the nerves in? Has that gotten improved in some way?
It has. This really, we started making a lot of advancements with our engagements with the military in the Middle East. We had so many young service members coming back with amputations and having significant complications. There was a lot of money and time and effort went into trying to figure out how to help with the nerve symptoms that patients were having, and also give increased functionality, which is kind of the genesis of targeted muscle reinnervation, was traditionally for upper limb amputees to try to get a more functioning prosthetic. And so, yes, the nerve techniques, particularly in the past 20 years, and particularly in the last 10 years, have really changed as it went from patients in military service members, and now this has kind of filtered out into our institutions. And I think it's quickly becoming, standard of care to do something, to do one of these advanced nerve techniques.
JD, you already had your hands full trying to adapt to life with one leg. How did phantom pain make that life harder?
Oh, it was, trying to get used to that new prosthetic, it was just excruciating. I was like, man, this has got to get better somehow. And over the time, it just never did. And I had to look for solutions. And my prosthesis doctor there at the Hanger Clinic told me to get in contact with KU. So I'm really happy I did.
So that's how you learned about this procedure that could bring you some relief?
Mm-hmm. Yes.
Okay. So, JD, you let us bring a camera into your surgery with Dr. Brubaker. We're going to take a look at some of that footage now, and a warning to the audience that this is real surgery footage. It can be graphic. We blurred most of those graphic parts, but let's take a look. Dr. Brubaker, can you walk us through this procedure?
Yeah, so right now we're seeing on screen one of my partners, Dr. Brent Wise, who does orthopedic trauma here at KU. And this is one of the wonderful things about being at the University of Kansas, where we have such a multidisciplinary approach. Just as what we find in most patients, sometimes it's not just one thing. So JD was having significant issues with nerve symptoms, but he also had an unstable terminal end of his stump that was causing a lot of mechanical symptoms. So this is where a team approach with somebody who specializes with microsurgery and nerves, such as myself, and somebody like Dr. Wise, who does a lot of amputee care as well, can really be beneficial. In this part of the surgery, once Dr. Wise has finished revising the amputation and stabilizing the stump, we're able to find the nerve, and this is pulling out his sciatic nerve, and you see the large bulbous end to the nerve, and more normal nerve up above, and that's what we're trying to get back, is to the normal healthy nerve, because we know the end of the nerve has been trying to regenerate, and it's just full of all these nerve fibers that are really quite confused trying to find JD's foot again. But what we do is then transect the nerve higher up, away from the site where the prosthetic is going to be, and then we give that a new target. So we find motor nerves and allow that sciatic nerve to grow into the motor branch of these nerves. And what that does is the sciatic nerve then says, okay, this is my new job. I'm no longer going to try to find the foot. I'm going to innervate the hamstrings, musculature. So as it starts to grow, then the brain and through the loop with the spinal cord realize, okay, this is my new job. So I'm no longer going to continue try to grow back and find the foot, because I have a new task. So that's the concept behind targeted muscle reinnervation.
Okay. So are you connecting sensory nerves to the motor nerves?
Yes. So which sounds a little bit off, but what it is we know the sciatic nerve at that level is mixed. And it's almost, I have to explain these things in clinic, and it is a bit, it's complicated for anyone to understand. But if you think about just how a large electrical cable can be shorted out just so easy, we know that even if there's a size mismatch, and even if there's sensory nerves, just giving that mixed motor nerve a target will create a loop that kind of shuts down that phantom limb cycle that patients can be in.
Yeah, that's fascinating. Is there a window of time after an amputation when TMR is most effective, or can it help people who've been living with pain for years?
I think that's the question moving forward, is, knowing that, 25% of people might have moderate pain, 25% of people have severe pain, but 50% of people have mild or no pain. Trying to figure out who gets this as a primary procedure, and then who gets this, do we wait and see if people have symptoms? I think it's more challenging once patients have had long-standing symptoms, and that's probably a year or two out, that there's a pain centralization process that's not completely understood. I think it can be more challenging to treat, but I've certainly had successes with people very late. I've done targeted muscle reinnervation in people that have had symptoms for 30 years. I think there can be a lot of success and a lot of changes, because the brain is incredibly plastic, and our perception of those things can really be altered. So
yeah. So it might mitigate somebody that's had chronic long-term phantom pain, but
absolutely,
it might remove it.
It's certainly worth considering. And sometimes we try things like diagnostic injections, and we try to maximize all the modalities that we may have to prevent another surgery. But it's a quality of life thing for patients. And just as JD was mentioning, this is a relatively new thing, and there's people that have been dealing with nerve pain in the community for so long, and just don't know that this is an option. So that's part of this, and I really thank JD for coming on this to help share his experience, because it's something that we need to help get the word out about.
Yeah. JD, how quickly did you start to feel relief from this phantom pain after surgery?
It was amazing. As soon as I woke up from the surgery in the recovery room, I kind of woke up and I was like, that's amazing. I really couldn't feel my foot anymore just from the get-go.
Kind of amazing. So life-changing.
Oh, yes. I mean, after I got the staples removed, I mean, my pain has just been very minimal. This go around is daylight to darkness between that first amputation that I received.
It's incredible. Dr. Brubaker, we spoke with one of your colleagues, Dr. Chris Jaley, on a recent episode of the Morning Medical Update. He helped amputate the arm of a Kansas farmer, then immediately reworked the nerves to interface with a robotic prosthetic arm. It's really pretty high-tech stuff. So beyond pain relief, how does TMR improve the way prosthetics function?
So a lot of the advanced nerve techniques that we have for amputees came out of trying to increase the functionality of upper limb prosthetics. And a lot of these are myoelectric prosthetics, so trying to amplify or increase the diversity of those signals for prosthetics. They noticed that when they did this, that people had a lot less pain, and people's phantom limb pain tended to go away. And that was when somebody said, well, why don't we try this in the lower extremity for patients? And that was really the beginning. And so when we think about targeted muscle reinnervation or the other nerve techniques, in the upper extremity, we're often trying to increase the functionality and get them to interface with these types of prosthetics. In the lower extremity, we're usually trying to just mitigate the pain syndromes that can go along with the amputation.
Okay. So more robotic functionality of upper extremities versus lower extremities.
Yes, exactly. And that's, you know, one of the advantages that we have here is that we immediately, you know, have access to people in Kansas City that can help our patients get set up with these prosthetics. I will oftentimes, if I'm going to do more of a scheduled amputation or a revision, I'll meet with the prosthetics team and ask them, okay, you know, how long of a residual limb do we need? What are the signals? You know, what can we do to improve, and what are their goals? And that conversation and team approach is a real benefit to the patient, I believe. Yeah.
JD, looking back, what would you tell another amputee who's struggling with phantom limb pain and doesn't know about TMR?
Oh, it needs to be put out there. This is so life-changing. I mean, my outlook on life has just changed 100% after I received this surgery. My pain levels has dropped by 90%. It's just amazing.
That's fantastic. Glad things are going so well for you, JD. We are here to answer your questions. Please send them in using the links on your screen, YouTube, Facebook, or email the Medical News Network. Let's check in with Doc Hawk. We're still following measles because the outbreak in Texas is still growing. I think the last tally is 505 is what I saw yesterday. And since we talked last week, a second child has died. The Texas State Department of Health says the child's doctor described it as measles pulmonary failure. Doc Hawk, can you explain how measles can sometimes go on to stop your lungs from working?
For sure, and I think we first need to address just the outright tragedy of what is going on. It's a tragedy if you develop the disease, and then of course a tragedy if you develop the complications, and of course if you die from this disease, which has largely been eliminated from the United States since the vaccine has been used for the past 6 decades. We have an easy way to prevent all of these things, so it is certainly a tragedy. What people don't understand is it's not just cough and cold symptoms and then a rash. There are significant complications that go along with this disease. One of those complications is pneumonia. And I think we just need to start by saying, what is pneumonia? Basically, pneumonia is an infection or inflammation in the lungs. It can be caused by anything, such as viruses, fungus, bacteria. We know that the measles virus can cause pneumonia. It can destroy the inner lining of the lungs. Now that also unfortunately sets you up for a secondary bacterial infection such as Staph aureus or Streptococcus. So this is a significant issue, and we do see a lot of complications and mortality from this as well. And it seems like from the news stories, this is maybe the reason that unfortunately that child passed away.
So measles set this up for an opportunistic infection by bacteria to create those lung issues. Is that right?
Yeah, and this is not uncommon. Certainly we know that a secondary bacterial pneumonia after a viral pneumonia can be common, especially in things like influenza. Now, we didn't really see it that much with COVID, but certainly this is not an unknown entity, and bacterial pneumonias are very common after influenza, but obviously we know they can be very common after a measles infection and measles pneumonia as well.
So have we seen any measles patients here at the health system so far?
We have not. You know, we are in contact with KDHE, also our local health, county health departments. We have a great system and process in place. All of our frontline workers know, all healthcare providers. We are very aware of that. So we do, when somebody is concerned about it, we've taken really the regular steps, number one, to keep them and our employees and the other patients safe, but also as far as testing. We've had a number of testing that has patients tested for measles over the past few weeks, and this includes PCR testing to look for the virus itself, but also looking at antibodies to look at acute infection. So we've had a number of potential patients that have been tested, but we haven't identified any active infections at this point.
Right. Well, thanks, Doc Hawk.
Yeah.
Appreciate it. We know many of you have questions, so let's head to Studio B with Alexis. Alexis, good to see you again.
Good morning. We have a question from Kristen Markway-Shaw. She wants to know if TMR is just for amputees or if it can be used for other kinds of nerve issues.
No, it's not just for amputees. So there are people that have nerve injuries where potential where the nerve is not able to be reconstructed, and they can have significant neuroma pain without being an amputee, and targeted muscle reinnervation or other of these nerve techniques can really help with neuroma pain from other sources.
Stu has a question about the success rate, and he wants to know if there are ever cases where someone doesn't see a reduction in pain or a reduction in the sensation.
Excellent question. It is very individualized, is what I would say. There are certainly some patients that have severe pain that have the procedure, and I think that their pain reduction is minimal. We've had good success. I think some of it comes down to patient selection and trying, knowing, have we maximized all the pharmacological things? Have we tried injections? Have we tried therapy? Have we tried all the different things that come along with it? And also figuring out, with an amputee or someone else with a pain issue, is there something else going on? Is it an issue with poor soft tissue coverage that's causing the pain? I mean, so everything's not just the nerves, but in general, if we work it up and the patient, I think the success rate can be quite high.
We actually have a follow-up to that question then. If you don't have the success you're hoping for the first time, can you try TMR a second time?
You can, and I think it depends. It depends on a lot. It's a complex question. It depends on what the site of the targeted muscle reinnervation is. Usually, if like in JD's case, we go up quite high on the sciatic nerve to get it away from the amputation site. Probably, if somebody didn't have success with that, I'd recommend that we try, other things other than redoing it. Sometimes, if the targeted muscle reinnervation is done really close to the amputation site, we can see more failures with that, and you can always consider trying it again. But hopefully, we don't have to do that, and it's successful the first time. That's our goal.
Amy has a question for JD. JD, Amy would like to learn a little bit more about your experience with your prosthetic limb. You talked about at the beginning of the program how you had some real pain when you were having that phantom limb pain. Have you been able to go back to the prosthetic? What has that journey been like?
I haven't been cleared to go back to the prosthetics yet. My surgery has only been like 4.5 weeks ago, so I got about another 3.5 weeks of healing before I can get cleared to go back into a prosthetic.
And Marie has a question for Dr. Brubaker. Marie writes, I've heard of mirror therapy for phantom limb pain. How does mirror therapy work?
Mirror therapy is another one of the modalities that we may try, first if somebody comes to see me with phantom limb pain. And the idea is that that's working with this super complex loop that has to do with your perception, sending the signals down the spinal cord, then to your amputated limb. And once again, the nerves are in this loop trying to find this residual limb. Sometimes we think this mirror therapy is the idea that you give an exact reflection of that amputated limb to try to retrain the brain to reinterpret that signal not as a noxious or painful stimuli, but rather as a more normal sensation. And it certainly can have success. It would be, before we jump to surgery or think about doing it, we do all the non-invasive things as a first step. So, once again, being a part of a big institution like this, we're able to get patients to our therapists who have some experience with this and see these kinds of conditions all the time and really make people's time in therapy worthwhile with some expertise here with our therapists.
I noticed, JD, you were nodding your head when Dr. Brubaker was talking about that. You've also tried mirror therapy, right?
Yes, I have. I've tried mirror therapy and several other techniques, and with my situation, there was just no relief from anything with the mirror therapy, and it was always just there.
Yeah. I have a question for Dr. Brubaker. Dr. Brubaker, you talked about how JD had something called an unstable terminal end of his stump that was also contributing to the pain. What is that, and what is an unstable terminal end?
Yeah, the idea is that when you have an amputation, that we use some of the muscles to cover the end of the bone, and that allows some weight bearing and some protection of the end of the bone. There can be issues where the bone is too long relative to the soft tissue envelope, so it leads to skin problems. In JD's case, actually, he had too much soft tissue at the end. So basically, when he was trying to wear a prosthetic too, that there was too much motion of that soft tissue envelope at the end of his stump, and that was causing some mechanical symptoms. And I think that's a critical thing to mention, and one of the reasons that we approach these as a team is because oftentimes I get referred patients that might be a question of a nerve problem, but I notice that they have ligamentous instability in their knee for those that have a below-the-knee amputation, or other issues with soft tissue coverage that we need to pull and figure out at the same time. So it's, I'm going to say at least half the time that I'm doing a nerve procedure, I'm also doing something else to make their amputation better from a mechanical standpoint or coverage point or something like that.
Well, this has been a great discussion. I'm grateful to our guests for being here and taking the time to educate us all. And I also want to get some final thoughts before we go. JD, we'll start with you.
Yes. All I can say, if anybody's dealing with any kind of nerve pain in an amputation or any nerve pain, I would suggest getting a second opinion, looking at this, doing your research, find a doctor that can help you, because I'm telling you, it is life-changing.
Dr. Brubaker?
I just thanks again, JD, for coming on. It's nothing like hearing it from someone who's experienced it, and thank you for allowing the cameras into the operating room. All this is a huge part of our efforts to kind of get the word out for those people in the community who may benefit from this. So thank you so much.
You're welcome.
Thank you both. This has just been an incredible and a fascinating show today. And my final thoughts are: please reach out, get educated, come to the University of Kansas Health System. We have excellent surgeons, just like Dr. Brubaker here, and specialists that can help with these. This is the tip of medical innovation and surgical innovation. So please reach out. Talk to us. We're glad to see you anytime. So thanks again to all our guests and to our audience. We'll see you next time.
Struggling to breathe her entire life, Jody Roberts was always told she had asthma. I'm Alexis Del Cid on the next All Things Heart, the true diagnosis she finally got, and the surgeon here at the health system who fixed the problem in one day, Thursday at 8 a.m.
Subscribe to our morning medical update and open mics with Dr. Stites podcasts. Now everywhere podcasts are available.